So without further ado, it's my pleasure to introduce Professor Rustam Al-Shahi Salman, who chairs our Medical Advisory Board. And just before I started, Ian actually messaged me to say it was 2007 when you first spoke with us. So wonderful to have had you join us on that journey. So Professor Rustam Al-Shahi Salman is a consultant neurologist and Professor of Clinical Neurology at the University of Edinburgh. He specialises in cerebrovascular diseases, particularly cavernomas, and his research has advanced the understanding and treatment of many neurovascular disorders. I think often we think you're just doing cavernoma, but you're not. You're doing many other things. And he's very much leading many studies in this field. Professor Al-Shahi Salman has been published widely. He's contributed to international research collaborations and clinical guidelines. And today, we're really pleased to have you talk about what have we learned in the last 20 years. And it's amazing what we have learned. So I'm now going to turn my video off. I'll keep my audio on just so I can let you know that we can see you and we can hear you. And I'm just going to pop the spotlight onto you now. There you go.
Lovely, thanks, Helen. Happy Saturday to everybody. I hope the sun's shining with you, and many of you are watching this in your garden rather than cooped up indoors. So yes, it's lovely to have these opportunities to reflect and look back, actually, and it wasn't as easy as perhaps one might think to look back over 20 years and work out what we've learned. But I'm going to share a few stories with you about what I've personally learned, what we've learned about cavernomas, and maybe a little glimpse at the end to set you thinking about what might be ahead of us. So before I carry on, first of all, my disclosures. So I'm paid by a university, the NHS, and the network of clinical trials units in the UK, because one of my research designs that I focus on is clinical trials. The grants and consultancies that I have are paid directly to my employer, the University of Edinburgh, and I was paid as a consultancy for the Sycamore trial by Recursion, which is the cavernoma trial that finished recently. I think more relevant to my non-financial disclosures, where I helped set up the Reduce Research Waste and Reward Diligence campaign, REWARD, which is all about making research more valuable and doing less wasteful research. I'm very concerned about climate change, so I took my professional association when I was president of it to become a member of the UK Health Alliance on Climate Change, and I've helped set up the Greener Trials movement so that the research design that I'm interested in, clinical trials, which can be quite carbon intensive, is as close to net zero as possible. So those are my personal biases. So where does my own story start, really? Why did I get interested in cavernoma? And that's going back more than 20 years. That's at least 30 years. So I qualified in 1994. So it's now a good 31 years that I've been a doctor. And it was after a couple of years when I moved to London to the Whittington Hospital, and you'll see Dick Whittington's cat there on one of the buildings, that I was first inspired to really go into research, having already been inspired that stroke was a very important disease when I was working with a phenomenally human and intelligent geriatrician, Nick Coney, in Cambridge. So my on-call shifts then were in the days when junior doctors worked probably more than 24 hours on the trot at a time, and where we were just busy all night in the emergency department seeing everybody who came in. And at the Whittington Hospital, I remember seeing people time and time again coming in with a stroke. As you heard from Daniel Walsh earlier, going weak down one side of the body, losing their speech or their vision, being comatose, being brought into the emergency department, where really all I was able to do was comprehensively assess their medical history, examine them, and work out how to support them as well as possible, whether it was with hydration or pain relief, or whatever. And then really the rest was down to the patient to recover with support from nursing staff and therapists. And it struck me that this was a tremendously important disease to individuals and their families and carers, but there was very little we could do. But at the same time as this problem affecting the blood vessels in the brain was presenting itself to me and there was not much I could do, we witnessed a revolution in the care of a blood vessel problem elsewhere in the body, heart attack, where over the preceding 10-20 years we'd identified several treatments that were beneficial for people with heart attack, whether it was aspirin up front or a clot-busting drug given through a vein, and later entering the blood vessels of the body and pulling the clot out of a blocked coronary artery causing a heart attack, or maybe even putting a stent mesh-like tube in there to keep the artery open. So it struck many of us who were becoming interested in stroke that these blood vessel problems were really quite similar between the heart and the brain, and maybe clinical trials of these treatments that were working in the heart might work in the brain as well. And so hope came to me while I was working at the Whittington when this new massive international clinical trial started and the Whittington Hospital was taking part. And all I had to do was obtain consent from the patient or their relatives, fill out a one-page form with details about the person's stroke, and then they were randomly allocated in this trial to either, as you see here, aspirin, 300 milligrams daily, or no aspirin. And then people were also randomized to other comparisons of either no heparin or 2 doses of heparin in addition, so that we had the opportunity in an enormous clinical trial to look at not just 1 but 2 treatments. And you can see here that there were almost 20,000 people randomly allocated in this trial and well over 2,000 participants in each group. So this struck me as a tremendously hopeful way of managing an as yet untreatable condition, and also just the way it was done to achieve an enormous study worldwide, to answer a question really convincingly with a very large number of people and improve the care we could give to people with stroke, was quite inspiring. So I thought, well, probably need to do more of those, because the problems aren't just fixed by aspirin itself, which was what turned out to be beneficial. Heparin was not. It caused more bleeding but did reduce clotting and overall had no beneficial effect. So there was plenty more to be done. So I thought, right, well, maybe stroke is for me and clinical trials are the way to resolve this problem. So I was at that stage a junior doctor, so I was learning the art of doctoring, which obviously focuses on individual patients, where we're looking at a person not just as somebody with a stroke or a cavernoma, but we're thinking about their age, their sex or gender, their ethnicity, their past medical history, their family history, the drugs that they're on, and really tailoring our treatment decisions to the individual. And of course, that art of doctoring is something that patients and carers really buy into. You want to go and see a doctor who's a human, who can talk to you and listen to you, and who's also an expert in their condition, so they can tell you as a person what the best thing is to do for you. However, how we work out what the best thing to do is done really through research, using the techniques and the fundamental study designs of epidemiology, the study of populations, because it's very hard to generate evidence that applies to everybody from just one person or a small number of people. So if you want to understand what the risks of a condition are, you're going to observe very large numbers of people in cohort studies and follow them forwards in time. Those are the sorts of studies that underpinned the risks that Daniel Walsh was talking about earlier today for people with cavernoma. But if you want to know about the effects of treatment, you have to conduct an experiment. And that's a randomized control trial where at random you're allocating people to one of 2 groups in its simplest form. So in that stroke trial I told you about, allocating people at random to either aspirin 300 milligrams daily or no aspirin. And people are randomly allocated one at a time. And it's ethical to do that when you're not sure if a treatment works or not, but you hope it might, and where you've got all the appropriate monitoring in place for participants to monitor their safety and also monitor the benefits of the drug, so that if it looks beneficial, the trial is stopped and people are allowed access to it. So this randomization process happened 19,435 times for all these participants in the study and divided them into two groups. And the reason we do that is because randomized control trials are the fairest tests of treatment. And that's because this process of random allocation creates two groups of people who are absolutely alike. If you've got 19,500 patients, dividing them into two groups means that the average age is going to be the same, the proportion of women is going to be the same, the ethnic mix is going to be the same when you're dealing with an enormous trial. The only difference is that one group gets a pill or treatment of some sort, might be surgery, might be medicine, and the other group gets an alternative. So what you're doing is comparing like with like, and that's why these trials are the fairest tests of treatment. And we follow everybody up in the same way, perhaps with brain scanning, perhaps with sending them questionnaires or seeing them in clinic. And then eventually when the trial is done, you unmask yourself to the results and you compare these two groups of people. If trials are very small, that balance isn't always achieved. So that the importance of very large trials is in creating two perfectly matched groups of people and also getting a very precise result because the numbers are large. Smaller trials may be subject to imbalances between the two groups and have much less precise results, so you can be less confident in them. But nonetheless, they're the fairest test of a treatment. So Mr. Walsh covered this earlier. There are two types of stroke, and I've told you the story about how enormous trials were revolutionising the care of people with ischemic stroke in the brain due to clotting. We were seeing whether aspirin or heparin worked to try to reduce the risk of clotting again. But people who were admitted to hospital with brain hemorrhage really were carried on being managed in the same way that everybody with stroke had been before this era. So for me, as somebody thinking this is an important disease, randomized control trials are the way to make progress with treatment, where was the big uncertainty? Where was the problem to solve? Well, as time went by, it really looked like brain hemorrhage was that. So looking back over more than 30 years now, since I qualified from medical school in 1993, if you look at what's happened over time for ischemic stroke due to clotting, before I'd started at the Whittington, we'd already established that looking after people on a dedicated stroke unit saved lives. That had been established in randomised control trials, randomly allocating people to being looked after in a stroke unit or a general ward. And just simply organising healthcare in that way was beneficial. And then around about the time I was at the Whittington, there were also trials of RTPA or alteplase, which is thrombolysis, this clot-busting drug given over an hour to somebody very early on, within 3 hours of the onset of symptoms of a stroke due to clotting. And then the aspirin trial, the IST, came out in 1997, and we had 3 treatments that we could be using for people with ischemic stroke. And then we've gone on to show how lowering blood pressure to prevent another stroke, lowering cholesterol in people with very severe stroke, relieving the pressure on the brain by taking some of the skull off can save lives, how thrombolysis works in a later time window, up to 4.5 hours, not just within 3 hours. And then finally, in our 3rd international stroke trial that was run from Edinburgh, seeing that thrombolysis works not just in the people under the age of 80 who'd been included in the original trials, but without any restrictions on age, thrombolysis worked in that group, age group over 80. And then the game changer for ischemic stroke has been thrombectomy. Just like in the heart, as I explained to you earlier, popping a catheter in one of the blood vessels, finding the blocked vessel in the brain, and then either sucking or pulling the clot out to restore blood supply. And since 2015, this has been most phenomenally beneficial treatment in medicine. 1 in 3 people benefit from it significantly, and that's a huge treatment effect for things that we do. And over the intervening years, there's just been one clinical trial after another showing that we can use this treatment effectively later on after stroke for particular subgroups of people, looking at people who've woken up and we don't know when the stroke started. It works for them too. And in using advanced imaging to assess how much tissue in the brain is at risk to influence these decisions. So the progress with stroke due to clotting has just been relentless. But looking back over the last 30 years, there's been much less progress with bleeding in the brain. So people with bleeding type of stroke were included with those with clotting stroke in those early trials of stroke unit care back in 1993, but we didn't really know then whether there was any difference in the benefits of stroke unit care for people with clotting stroke and bleeding stroke. And it took until 2013, 20 years later, when I was knee-deep in doing clinical trials, when I encouraged my colleagues to look back at these trials and compare how much stroke unit care benefited people with clotting stroke and bleeding stroke. And actually the answer was just as much. But often people with bleeding stroke were looked after in neurosurgical wards or left in general medical wards. So this was basically bringing people with bleeding in the brain that wasn't commonly perceived as a type of stroke to benefit from the same management that their counterparts with clotting stroke had. We also definitively showed that if somebody was lucky enough to survive a brain hemorrhage and recover, that reducing their blood pressure definitely prevented the risk of another stroke. So that happened in 2004. And really, there's been very little else until more recently, showing that bundles of care with blood pressure lowering, reversing blood thinning drugs if needed, managing glucose levels and so on, a bundle of care given for patients with brain hemorrhage also improves outcome. Those studies were almost exclusively done in China, so their generalizability elsewhere is unknown, but we have seen benefits from bundles of care in the UK. And then much more recently, we now definitively know that within 3 hours of brain hemorrhage, reducing somebody's blood pressure significantly improves their outcome a little bit. So there are a few things we can do, but you can see that progress has lagged behind clotting stroke. So that, if you like, has been the context of my professional practice over this time. And I think what I've personally learned going through it is that it takes a long time to eventually answer a clinical question. Unless you've got an enormous pharmaceutical company with a very large amount of money and a strong financial interest in proving that a treatment works behind you, it takes a very long time to line up the evidence from observational studies, cohort studies, to then generate the information that says a clinical trial is needed to address a treatment question, then eventually to get the funding for a clinical trial, start it up and do it and then publish it. It takes an enormously long time, and if only we could make that process quicker and more efficient, we'd have progress in healthcare faster. So I started by moving to Scotland from London to do an epidemiological study to look at how common causes of brain hemorrhage were, and that included cavernomas as well as AVMs. And then, having found those people and saying how commonly they were diagnosed, to follow them up in time to look at their prognosis and their risk of bleeding again. And then to say, well, in standard practice, how do people who are treated compare to those who are not treated, and what's the outcome? And then when you've got that sort of information from just observing what's going on, you can say, well, it's so obvious that treatment with neurosurgical excision, for example, improves outcome, that we should just be doing that in everybody. Or you're saying, well, is there a balance to be struck, like Daniel Walsh was saying earlier, between the risks of the condition and the risks of the treatment? And is it too difficult to work that out with a randomized control trial, or do we need to do one? So my career started with observation, then moved into these randomized control trials that a decade or more beforehand I'd been hoping to do, but was just getting experience with. So I helped other people with their trials to learn the trade, if you like. And then since then, I've been doing my own randomized control trials whilst mixing clinical training in blue with research training in orange, sometimes whole time. But now my life is a mixture of clinical practice and on call at the weekends and overnight for stroke care, but doing research as well on some days of the week. And what I've learned is that sort of career takes it out of you and leads to significant hair loss, and you see this shadow of a man from this bright aspirational young doctor back in those days at the beginning of it. But of course, there's plenty confounding that, isn't there? There's just simply getting older. But it seems to me that the more hair you lose, the closer to the truth you get. And so if anything, my journey through research has told me that the balder I get, the more likely I am to be solving a problem correctly. So what about the BC era, not the before Common era, but the before Cavernoma Alliance era? What was happening every day when I'd moved to Edinburgh from London and I was seeing people with Cavernoma in my everyday practice? Well, I think a lot of individual efforts, mostly by individual neurosurgeons, to just report on what their practice was, had led to several discoveries. And back in 1987, Dr. Rigamonti had first described the appearance on MRI, magnetic resonance imaging scans of the brain, of these caverns that you see on pathology, on tissue that surgeons had removed from the brain. They had a distinctive MRI appearance, this popcorn-like appearance on MRI. And remember, MRI was only just beginning to be used in the 1980s. So it took some time to actually recognise cavernoma, and that's when we first really knew how to recognise it in life without having to operate on people to remove the cavernoma. And then people noticed that some people with cavernoma were affected in multiple generations of a family. You see a family history here affecting with autosomal dominant pattern of inheritance. And we learned that there were some people not just with one cavernoma, but about 1/5 of people with cavernoma have multiple cavernomas. And these were the ones that tended to run in families. And then people were on the hunt for genetic diseases, single gene diseases back in those days. And 3 different genes were found to have mutations that underlay these familial cavernomas. And those genes have now been identified and can be tested for in clinical practice. But at that stage, we defined what cavernomas looked like, we knew about their family history, but actually the studies of prognosis were very, very few and far between, and most of them were extremely small. At this time, the largest single study was of about 130 participants. And that, as you can understand, will give you a very imprecise answer about outcome. So we had a lot more to learn about prognosis, and also we'd never done any clinical trials of treatments, but there were 2 treatments available: microsurgical or neurosurgical excision, you see here, and also stereotactic radiosurgery, focused radiation treatment, which was being used. But nobody was experimenting when these treatments were first introduced to say, what's worse, the treatment or the disease? Should we be doing this? Should we not randomise people to one or the other, and then we know from the start whether it works? And this happens time and again in medicine. New treatments are released and everybody gets extremely excited. They want them to be used in practice, but we don't actually have the reliable evidence to show whether they work or not. And then it's a real battle to work backwards against clinical practice to say, hey, there are pros and cons here. The more we use this treatment, the more we realise there are some downsides, although it can give wonderful results in some people. Shouldn't we have done a randomised control trial at the beginning? So there were a lot of uncertainties about the outcome for people with cavernoma and how and whether they should be treated. And then around about this time, there were really the genesis of the first patient support groups, the first patient advocacy groups. And I think, if my memory is correct, and Ian, our cavernoma historian, our caver historian, as you might have it, Ian, was in 2002, Connie Lee in the USA set up the Angioma Alliance, which I think was the first support organisation for people with cavernoma. And she's an extraordinary woman, and was basically on the global hunt for people like me who are interested in caring for people with cavernoma and doing research. So just at this time, we were beginning to see, in the USA at least, the beginnings of patient advocacy organisations. So that was my everyday. A lot of uncertainty, and this would just happen time after time when I saw people with cavernoma. But I think over the last 20 years, we've really entered the era of collaboration in all sorts of ways, which has brought us a long way in understanding and managing cavernoma. So we've understood a lot about the genetic causes. As I said to you, that's continued over the last 20 years with the identification of 3 genes that account for almost all of the people with familial cavernoma. And then understanding those genetic causes allows us to understand what the mechanism might be when studied in animal models and humans behind how cavernomas develop, why they may grow or multiply in the familial version of the condition, and what the mechanisms underlying bleeding might be. And you see some huge scientific initiatives that have arisen into that from the collaboration between scientists, doctors and patient advocacy organisations, and there are a few of them listed down the left that were part of a rare diseases clinical research network in the USA that's carried on over the last couple of decades to continue to find commonalities, differences and individual findings for each of those diseases that's taking part. Another thing I noticed when I came into the cavernoma world was that what some people were calling a hemorrhage was different from another. We hadn't really defined anything other than the MRI appearance of cavernomas, and there was a lot of confusion about whether some symptoms like headaches were due to cavernoma or not, and how we should be thinking and defining these things so that people could standardise the way they described people in their research studies and described the outcomes. So we were comparing like with like, not twice the risk in one person's study because the way they categorised bleeding was, just the appearance of a little bit of new blood on a scan, whereas it was half the risk in another because somebody said, well, bleeding's significant if it also causes new clinical symptoms that affects the patient. So you'd see these differences between studies. So I was very grateful to Connie Lee and others for allowing me to say, look, let's create some standardised definitions and a clear way that researchers and doctors in clinical practice can say what is and what is not a bleed from a cavernoma. So that led to a collaborative paper with the Angioma Alliance Scientific Advisory Board. So some early scientific wins for the patient advocacy organisation, which was now starting to reach out across the pond to Europe and other parts of the world. We'd all get together, a very small number of us in the USA each year, and work out what needed to be clarified to push the field forward. So those standards were the beginning. And then myself, I'd come to Scotland, as I told you, in 1999 to start this Scottish intracranial vascular malformation study, a long-term study looking at all new diagnoses of AVMs and cavernomas and other vascular malformations in the whole population of more than 5 million, and then follow everybody up through their GPs or questionnaires to the patients over time to learn what the long-term risks were. And we've actually now just completed our 25-year follow-up analyses of people with cavernomas, and they're under revision and hopefully acceptance by a big journal at the moment, so we can describe what the very long-term risks look like for people. And just to cut to the chase, the risks after a bleed are all front-loaded in the first 5 to 7.5 years, and it's extremely rare for people later on to have another bleed. So it's very much a condition that clusters when bleeds occur. But in this last 20 years, what I did was not just do the study in Scotland, but say, look, that's still only 300 people over 10 years in Scotland. That's still too small to generate really reliable evidence. So what do you do with a rare disease? Well, nobody else was doing population-based research that was then therefore representative of everybody with cavernoma in the UK. Where else were they doing this? So I had to bring all these studies from all over the world together to eventually generate more than 1,500 people or so in one study where everybody defined things the same way, where then statistically we can be much more precise about what people's risks are, and we can actually start investigating things that put people at higher risk or lower risk. You can only do that with big numbers. So this was all facilitated by researchers understanding that, but also the patient advocacy organisation being there at the centre amongst us, saying, look, we just want to make progress with this condition. We want to understand it better. We want to improve outcome. And we know we understand we can do that by all of you getting together. So that played into the hands of people like me who knew that big studies of a collaborative nature were needed to answer these questions. And then, of course, in the after Cavernoma Alliance UK era, we've not only had Angioma Alliance in the USA, but also multiple European cavernoma support organisations, all brought together by Jana Bergholz and others under the European Cavernoma Alliance umbrella, and of course many other support organisations in other parts of the world, including Canada. So this growth of patient advocacy organisations allows you all to collaborate, but also to make everybody in the whole cavernoma ecosystem collaborate to improve the lot of people with the condition. And that, for me, has been tremendous, because research is so often this competitive environment where people are trying to forge ahead and find knowledge and be the first ones to do that. But for me, it's not about that. It's much more fun working in teams of people, making the world a smaller place and bringing everything together so that we get a much more reliable answer. The benefits of collaboration are huge. You just have to put yourself second and focus on really what the common goal is for the condition and have fun working together in teams. So actually this collaborative work between a patient advocacy organisation and researchers and clinicians is really fulfilling. And several things came out. We had the first guidelines for the management of cavernomas. That was a collaboration between Cavernoma Alliance UK and Genetic Alliance UK. And really these were making the point that there wasn't really adequate evidence to make any confident guidelines about what clinical practice could be, because we had these small cohort studies looking at prognosis and no randomized control trials to tell us what to do. So this, if you like, created a baseline to say we need to do better than this. We can't be sufficiently informed about clinical care, like NICE is, for example, for the management of Alzheimer's disease. We need evidence to improve these guidelines. And then 5 years later, there were the Cavernoma Care Guidelines that Angioma Alliance led that created, I've deliberately put this here so you can't read it, there's just far too many recommendations to be able to talk about, but this ranked the recommendations. It didn't say there are no strong ones that we can make. They said, here are a lot of recommendations that we think we can make, but most of them have got weak evidence behind them. But as a group of experts, we think this is the best thing we can do at the moment, but we need to do clinical trials to forge ahead. So those guidelines have just been updated this year, and they're just out again, so 8 years later, based on all the progress that's happened in the meantime. I think the other thing that patient advocacy organisations have done is that they have enabled people to tell their stories, and people being courageous about telling their stories in the public eye has also drawn attention to those advocacy organisations and improved the lot for people with the condition. So here's an article that I read in a weekend supplement about Miriam Szabo, who had been in one of the James Bond movies, who'd had a bleed from an aneurysm, and Sasha Bonsa, who told her own story about having a brainstem cavernoma that had bled not just once but twice, and her own dilemmas about whether or not to undergo surgery. She had surgery in the USA, and the cavernoma came back afterwards and needed to be operated on again. So Sasha's story was not straightforward, but she was very brave to tell it, and I think it draws attention to the condition and can only do good for awareness about it. So it was during those last 20 years really that neurologists and neurosurgeons started talking to each other, and we work much more as a team now, but the specialties were quite divided in the past. But as I've said to you, I'm much more into team working in medicine, and Neil Kitchen, to his great credit, had heard me speaking at one of these Angioma Alliance meetings, and I'd raised the issue that I thought we should be doing clinical trials for people with cavernoma. And of course, a lot of people thought that was impossible because it's a rare-ish disease and therefore hard to get large numbers of people. But I wasn't going to let that beat me. And here's this really nice letter from Neil that I dug out of my Cavernoma file in my office yesterday when I was thinking about this talk, where he's saying, maybe a trial's not a bad idea, let's get together to discuss it. So that was gold dust for me, because I knew as a neurologist I wasn't going to be able to persuade a community of neurosurgeons to do clinical trials. It would take one of their own to speak to them and do that with me. So the next step on the journey, if you like, from this kind of everyday diagnosis, uncertain about prognosis, not sure about treatment, was building this case, this awareness, this groundswell of interest in the condition, and this spirit of collaboration between all these different players to say, look, we don't know enough about this condition, we need to improve on that, how are we going to get there? And that's where we were, the approach that was being taken to this in the UK were played into our hands, because the powers that be realised that the patient voice is tremendously important, and patients really should be involved in setting the priorities about their condition, and they should be involved in designing the research, they should be involved in overseeing the research, they should be involved in delivering it, interpreting the results and disseminating it. The whole life cycle of research should have patients involved. So there was this thing called the James Lind Alliance that was started by Ian Chalmers, one of the fathers of evidence-based medicine in the UK, now in his 80s living in Oxford, and was then adopted by our biggest national funder, the National Institute of Health Research. It was named after James Lind, who many of you may know was a Scottish physician, the ship's doctor, who did the first controlled trial. It wasn't randomised. It's the first controlled trial with 12 sailors on board a ship who had scurvy, and he divided them into 6 groups of 2. And if I've done anything to, if any of my messages have come across to you today, you'll know that those are tiny group sizes. But, and as you may know, he divided those 6 sailors into groups where some had to drink seawater, some drank cider, others drank sulfuric acid, and a couple of them were lucky enough to be given oranges and lemons. And what they found was that really it was the 2 with oranges and lemons who were almost cured of scurvy within a week, whereas none of the others convincingly were. So this was demonstrating the value of having a control group, so you can compare a treatment with the alternative. So that's why his name's been given to this alliance, whereby people can say, look, what don't we understand about a disease? What are the priorities to do research into? And then let's do the clinical trials to resolve those uncertainties. And that's where some heroic people from Cavernoma Alliance UK came to the rescue, and it was an absolute pleasure working with Ian and David and many others who you see here on getting funding for this James Lind Alliance. We had to be quite erstwhile in obtaining that, and resourceful. So there were multiple different sources of funding for this. It must have cost about £20,000 to £25,000 to do it properly. And we just systematically looked at the existing evidence, gathered the uncertainties, asked patients and professionals and carers and parents and others what they should be doing, and prioritised them. And then here we were agreeing on the top priorities. And although that sounds easy, that we really built on the guidelines from 2012, and it took us a couple of years to even get to a protocol for this, having raised the money, and then doing surveys through 2015, and then eventually by 2016 prioritising the top 10 questions, which we then published and launched at this meeting in London. And the number one uncertainty was whether treatment with neurosurgery or stereotactic radiosurgery or no treatment improves outcome for people with brain or spine cavernoma, and several other questions that you see here about the development of cavernoma, what the risk of bleeding is the first or multiple times, and could drugs targeted at cavernomas improve outcome. And so that's what then led us to be able to apply for funding, saying, look, this is the number one uncertainty, let's try and address it. So we applied to the National Institute of Health Research in a huge collaboration, and was successful in getting funding for a pilot phase trial, because NIHR knew we wouldn't have enough people in the UK to actually definitively answer the question about should people have treatment with surgery or not, but we could at least do a pilot study to show whether it might be possible. And this was really only possible with a dynamic duo of myself and Neil Kitchen, representing both of the specialties that are involved in managing people with cavernoma to lead our communities to recruit to this trial. And there were many institutions and people who you see here involved on the trial management group, on the patient advisory group. I'm very grateful to many members of Cavernoma Alliance UK and Cavernoma Ireland for joining that. Some real stellar people on the trial steering committee, including David and Ian, and then finally a data monitoring committee of people who'd done neurosurgical trials before. And that took us from when I started doing population-based research in Scotland in 1999, 25 years, a quarter of a century, to then finally get the results from CARE and publish them. So that was quite a journey. But we got many hospitals involved in the UK, not as many as the 40 we would have liked and not as quickly as we would have liked, largely due to the impact of COVID. But ultimately, here's what we set out to do in terms of patient numbers to recruit, 60 over about 18 months. And we were lagging behind a bit over time in the green line, but then with a 6-month recruitment extension, everybody really got going to meet our recruitment target, and then eventually we recruited 72 people rather than 60. So the trial did really well, and it showed that a trial was possible. It showed that from qualitative research we could understand more about the process of approaching people. It showed us that our approach to the types of treatment and how we were assessing them was acceptable. And it showed us that a third of people who were approached and eligible were randomised, but that's quite a large number, 2/3 who were declining. And many of those people said they prefer an alternative to surgery, and I'll just come to that in the closing minutes, Helen, to describe that before leaving time for questions. So what are the alternatives for surgery? This is starting to become a bit more futuristic. And beta blockers, drugs often used for tremor and high blood pressure, were found in our Scottish cohort. Over time, you can see over 14 years of follow-up along the x-axis, to lead to a lower risk of having a bleed during follow-up in comparisons to people who were not on beta blockers. But these beta blockers were being used for other reasons. So we just took this opportunity to see whether they made a difference. And that eventually led to a randomised control trial done in Italy for people with familial cavernoma, involving just 83 people. Our cohort study was 300 people, so it was much less precise. But it did show a similar outcome for people on propranolol, a lower risk of bleeding, but it was too small to be precise or statistically significant. So you could just say this was a suggestion that it might work, but not a definitive trial. What about other classes of drug? Well, statins, also in our population-based study, might have been beneficial in reducing the risk of bleeding from cavernomas, but that was not statistically significant. And Issam Awad, who will be talking to you about this in a moment, has led a very detailed, comprehensive clinical trial in the States using novel imaging methods and all sorts of things to better understand cavernoma, which again showed what I think was a suggestion that as to atorvastatin might be beneficial, but it was far from being statistically significant because the trial was too small to definitively answer the question. But again, it was like the CARE pilot trial, a small trial that showed that the trial could be done. And then finally, what's coming up in the future? Well, we'd also looked in our population-based study in Scotland at whether people taking an antithrombotic drug like aspirin or warfarin, who were on it usually for other reasons, not for the cavernoma, whether they were at lower risk of bleeding than their counterparts not taking those drugs. And you can see that our cohort study here at the bottom in 2019, this dot is to the left-hand side of the line favouring antithrombotic therapy, but the precision of the result is indicated by the horizontal line through each dot. And you can see that this horizontal line crosses this vertical line here, which is the line of no effect. So we could say that things were going in the right direction. The risk of bleeding was lower for people on these drugs with cavernoma, but the precision was not good enough to say it was definitely effective. And you can see there were several other smaller studies that had been done in the past of the same drug class, but then when you put them all together in meta-analysis, which is another thing we can do to try and enlarge the numbers in our studies, you can see a very precise association between the use of these drugs and a lower risk of bleeding. which might be completely the opposite of what you expect for a bleeding condition like cavernoma, but in fact it might be thrombosis, clotting in the cavernoma, that triggers bleeding. So this finding's been around for a long time, and we're hoping that we succeed in getting funding from NIHR, and Helen and Cavernoma Alliance UK have been behind this, for us to do a much bigger trial than the CARE pilot trial to show whether aspirin might be beneficial in reducing bleeding for cavernoma. So we're keeping our fingers crossed for that. I'll skip over that slide. So I'm just going to end here with what I think the next 20 years might hold. And I think as a UK patient support organisation, we have to remember that research is only possible here in the context of the NHS, and that research funding is going to be given to things that are consistent with the priorities set for the NHS. And you'll be familiar with the 10-year plan that's coming up for the NHS and is yet to be announced, and the government's been consulting on it, where Lord Darzi has already said he thinks there are 3 strategic shifts the NHS needs to make. We need to be thinking about more community-based care and less in the hospital. We need to stop using analogue, old-fashioned solutions for things and move into the digital era. And we need to think not just about treating conditions once they've happened, but preventing things happening in the first place. So those are 3 lenses through which Cavernoma Alliance UK should really be thinking about how the condition should be progressed in the future. And I think one way of us doing that is data science. At last, the International Classification of Diseases, version 11, has a code for cavernoma, but it never existed in the earlier one. So we can now use coding in the future to do very large-scale studies from databases of people with cavernoma, databases of people cared for in hospitals for cavernoma. We need to carry on doing clinical trials, and whilst surgery remains a really important intervention for some people with cavernoma, the majority don't have it or don't want it and would prefer a non-invasive treatment. So we need to be thinking about drugs, stereotactic radiosurgery, focused ultrasound, gene therapy perhaps. But to make all of that succeed, we need to carry on collaborating, and it's not good enough for us to collaborate in the UK because the disease is still very rare for us to be able to achieve anything really significant with the UK alone. We need to collaborate worldwide. So my final slide is a thanks to all of you who've participated in our studies, who've supported this agenda, who've raised funding so that Cavernoma Alliance UK can achieve this work. And that starts, I think, really historically with Connie Lee, who's been an absolute driving force behind cavernoma research worldwide, starting in the USA and bringing everybody together internationally. Huge thanks to Ian Stewart for being there at the beginning and setting up Cavernoma Alliance UK and tirelessly campaigning and forging ahead, not only for the research agenda, but to try his best to make me gain weight with his endless supply of Thomas Fudge's flapjacks that he's given me over the years. Very special thanks to David White, who's again, energy, intellect, quality of work, dedication and commitment to doing that James Lind Alliance priority setting partnership and us doing the CARE pilot trial was instrumental to our success. And of course, huge thanks to Helen Evans, who's been there since the early days of the CARE pilot trial and with boundless energy and enthusiasm continues to keep Cavernoma Alliance going as we quest for treatments to improve the outcome of the disease. Thank you all.
Thank you so much, Professor Al-Shahi Salman. If you want to stop screen sharing now, that'd be super. I think what that all shows is what a journey, and it's just wonderful that early on you had that passion to see this through. And I wasn't fully aware of all that history in respect to stroke research, so I've learnt a lot from this. And no one will really appreciate quite how much time you put into those research applications. We've just done one together. They're incredibly extensive, and to be working so hard for the cavernoma community and to give us access to the CARE trial, and hopefully another trial would be incredible. Thank you. So we're going to have time just for a couple of short questions, and no surprises, they've already come in. So I'm going to fire those to you if that's all right. Is that okay? Marvellous. If you just want to pop your microphone on. So the first question I've got is from somebody, and I think just to reiterate, we know you can't give clinical advice, so you're only talking in general terms. Someone has a spinal cavernoma and it's in their C2, C3. It's not bled, but it fills the whole cavity and it's causing disabilities. And they're wondering, could it be causing those given that it's not bled?
Yeah, so cavernomas can cause symptoms just simply by occupying a part of the nervous system and exerting pressure on it. So the growth of the cavernoma can do that. But one of the most common ways that people with cavernoma come to medical attention is by bleeding either into the cavernoma or outside of it. So often people assume that it's only bleeding that can lead to those symptoms, but certainly the space that's occupied by a cavernoma and its growth can do that. As you've heard from me when talking about aspirin, I do think that the slow flowing blood through cavernomas can sometimes clot, so they can sometimes expand and grow and cause pressure on surrounding structures from clotting within the cavernoma. So there are a variety of different ways by which cavernomas can cause symptoms, not only bleeding.
Thank you so much. So the next question is from someone who thinks she's perimenopausal, and she's a bit worried about the menopause and change in hormones and potential increased bleed risk. And she's just wondering, is this going to be a problem for her because of her cavernoma?
Yeah, I think it's actually the opposite. So there's been some preliminary work done looking at whether women taking combined oral contraception or estrogen-containing hormone replacement therapy might actually be at higher risk of bleeding from their cavernomas. Very early days, hard to be conclusive, but it seems that there might be a slightly higher risk of bleeding in women taking estrogen therapy, whether it's for contraception or HRT. And that might be because estrogen makes clotting a little bit more likely. So if clotting is what triggers bleeding from cavernomas, then it might be that people taking the estrogen supplementation are at higher risk. That's just a theory, and the work is in its infancy, but again, we need much larger collaborative studies to look at questions like that. I don't know of any higher risks to women after the menopause than before, to reassure you.
Thank you very much. And another question, particularly linked to women's health, is about urinary tract infections. So somebody's written in to say that they had heard Professor Howard mention that they can be dangerous for cavernoma. They're experiencing them. They're thinking, what can they do to stop them, and how dangerous are they?
I don't actually know of any data showing a link between urinary tract infections and higher risk from cavernomas. Having urinary tract infections is bad enough anyway, and having them frequently is awful too. And there are various things one can do diet-wise, as well as investigations that can be done to look for underlying causes and treatments for them. So I think, quite apart from whether they might or might not worsen the cavernoma, it's definitely worth investigating and treating them. But it's hard for me to speculate on what the cause might be and how to resolve it.
And given that they've mentioned Professor Howard, it's quite helpful. We've got him on next. That's. I can pose the same question to him again and see if he can add anything further. And then just two other quick questions. So somebody has said they have headaches in their right temporal lobe. Also, they have a cavernoma in their right temporal lobe, and they're getting headaches. But the headaches has been dismissed as not being related to their cavernoma, and they're wondering whether it could be related given their location.
Yeah, it's really difficult because unilateral headaches, one-sided headaches, really common in the population, especially migraine, which is usually one-sided, although it can generalise. Cavernomas are also fairly common, lurking in our brains without people knowing about it. So it's about 1 in 625 people has a cavernoma, and they don't know about it. Hasn't caused any symptoms. So if you combine a really common disorder like migraine, which affects 1 or 2% of the population, with cavernoma, which affects 1 in 625 of the population, it's a lot of people who have both migraine and cavernoma. So I think just because the headaches are on the same side of the brain as a cavernoma, which hasn't bled, it's hard to be certain that the two are linked. And certainly, unless somebody's had a bleed that's clearly caused that headache, it would be very hard to persuade a neurosurgeon to operate to remove a cavernoma because of headaches in the absence of bleeding. So I think the most important thing, again, like the urinary tract infection question, is urinary tract infections and headaches are awful, but there are quite a lot of things we can do, both in our lifestyle and with medical treatments, to try to manage them. So I think the thing to do is focus on the symptoms rather than the cavernoma.
Thank you so much. And I just have one question, and then unfortunately we're going to have to bring it to an end. And that's about LIT. So some of our members are aware that this was recently licensed for epilepsy that can't be treated through medication. And some of those patients are cavernoma patients. But we've got somebody wondering, can it actually be used for the cavernoma itself if it's bled in the brainstem? So if you could just answer that question before we finish.
Yeah, so surgery obviously is always done very carefully when it's undertaken, but surgeons are interested in adjuncts, extra treatments they can use at the same time as surgery to try to improve the effectiveness on it. And I'm only familiar with very small studies where this laser intimal therapy treatment has been used for the management of people with epilepsy due to cavernoma. I'm not familiar as a neurologist with its use for people with cavernomas in the brainstem. So as far as I know, I haven't read research studies documenting what the outcome of that is. But if your neurosurgeon is an expert in LIT, they may know more. I'd advise you to talk to them about it.
Thank you. And just to signpost, we had a clinician come on to talk about LIT for the treatment of epilepsy, and that's on our YouTube channel. So to the person who asked, if you want to go to YouTube, search Cavernoma Alliance, there's more there. But as Rustam said, it's very early days, and actually the evidence is in small numbers and only emerging. So everyone, we've come to the end of this webinar, and I think there's a wonderful call to action here, which is, if a research trial gets funded, we need you. It makes such a difference. It may be that treatment may or may not work for you, but you could have the potential to improve treatment for generations to come. It's a wonderful opportunity. And I think you've seen here how carefully Professor Al-Shahi Salman's considering that and trying to design trials that are going to improve standards of care for people with cavernoma. And our resident caver historian, I like that term, Dr. Ian Stewart, has just said you're absolutely right on all the dates. We formed in 2005, first conference in 2007, and it was Connie who established Alliance to Cure under a different name than before. Thank you ever so much for giving up your Saturday to speak with us today. It's been incredibly generous of you, so thank you so much.